All right. So talk about chronic disease self-management and heart failure. I think this slide really summarizes this problem quite well. Heart failure is the most common reason for hospitalization in adults over 65, and hospitalizations are very, very expensive. Heart failure goes through several stages: mild, uh, which can be controlled by drugs, diet, fluid restriction, simple, and the more advanced stages, which are relatively irreversible, requiring high-end mechanical support in hospital. Now, heart failure affects 5 million Americans and about 500,000 new cases every year. The cost is about 25 to $50 billion per year. And in America, there are about 6 million admissions per year. Now, in Australia specifically, uh, heart failure affects those above 65 years of age. There are about 300,000 new cases, 300,000 cases in Australia and 30,000 new cases per year. Below the age, between the ages of 35 and 64, there's 2 per thousand, and between 65 and 94, there's 12 per thousand cases. So it's a disease of advancing years. And the estimated cost is $400 million per year. And you can imagine in different countries what that will translate to in terms of cost. The lifetime cost is 2% of the national health budget. The risk factors are ischemic heart disease, smoking, hypertension, obesity, diabetes, and valvular disease. The relative risk is greatest with ischemic heart disease, and obviously these individual risk factors also cause ischemic heart disease. More specifically, is this slide visible? Because I think if it's not visible, it'll be a bit difficult. This basically shows how the prevalence of each of these as risk factors in heart failure. Despite you having ischemic heart disease, 55% of patients with heart failure will have hypertension, 40% diabetes, 1 in 3 ischemic heart disease, metabolic syndrome quite high, and obviously the other risk factors, including cholesterol, renal failure, atrial
Oh,
fibrillation, and rheumatic heart
okay.
disease.
Actually, the slide was not visible, but I think if you could click the up in the top right
Top
view,
right, yep.
then you can like have full screen or whatever option in the top right.
Okay, let me give you full screen. It's amazing, this technology, how difficult. I've only got to use this stuff during the COVID period. Before this, I didn't even know how to
Oh,
use these things.
if you didn't get it, it's okay.
Is that better?
Yeah, that's much better, sir.
Okay. All right. All right. So I think this is the side I was trying to show you basically the number, at least 1 in 3 to half will have at least one risk factor if you have heart failure. Now, with new heart failure and previous heart failure, again, hypertension is the leading cause worldwide. Okay, now why is this really a problem? Heart failure has variable severity. So if you come to a hospital setting, you can tailor the management quite easily. But if you come from a community setting, mild heart failure is very easy to treat, but severe heart failure becomes more difficult to treat. If you add in the comorbid burden, particularly with increasing age, and I've showed you several of those, the uptake of post-discharge services, particularly cardiac rehabilitation. And now if you're living within the vicinity of hospitals, it's easy, and you move further and further away, it becomes more difficult. So geography, demographics, access to hospitals, access to subspecialty allied health, language and cultural issues become increasingly relevant. Now let's take an example of several populations. I put here basically the types of population you see in Australia: Caucasian population, indigenous populations of older and younger. So if you take an older indigenous person, now this person at a younger age has more severe heart failure, as you can see by the ejection fraction of 35. He has more risk factors as well. Now, if you look at the way medications are provided, now this on the left here shows his pill burden traditionally with the conventional way of treatment, and this when you use once daily. So for example, if you're using carbidopa, it's a medication that's going to be used twice daily. You have to think about where this medication needs to be stored, how easy to take, how it fits into the lifestyle of individuals and things like that. And with the previous talk, we talked about diabetes. Metformin can be given either once daily through a controlled release or 3 times a day through the non-controlled release. And this is the cheapest formulation, the non-controlled release, and it's given by hospitals, even in person and any basically most hospitals. So it becomes, the pill burden for patients becomes increasingly, all right. So for this patient, in the traditional sense, he will receive 15 tablets a day over 3 courses. And this is a person who has an indigenous lifestyle and lives far away from hospital. Now, if we look here over as a Caucasian male, the difference between this patient and indigenous patient is because of insurance status, they have access to once daily as well as alternate medications, and the pill dosing for the same condition is far different. And I'll explain how that's relevant for self-management later. Now, we look here at the medications as well. Different medications have different properties against heart failure. And some of these medications have increasing side effects. So for example, if you want to be able to use SGLT2 inhibitors, angiotensin receptor antagonists, long-acting, or different types of ACE inhibitors, you must first of all have the understanding to uptake medical services and also understand how to follow up medical services. And these come into the realm of good self-management. Now, in terms of the taxonomies for chronic diseases, it's gone to, is it not come back? It's come back again to the, can you see this slide?
Yeah, I can see.
Okay, so basically now if you look at how diseases are managed, the important taxonomy, at least in cardiology, has come from Krumholtz in 2006. Now he's devised an 8-fold taxonomy, and obviously you can look at 9th where you got other models. Now the first is the patient population that you're looking at, the risk status, the comorbid conditions, and non-clinical characteristics. The second is who receives this and whether that patient has adequate care providers and adequate caregivers. The content of the information. You know, if a lot of the medical literature is given in complex language, it's very difficult to understand. The personnel that's going to give it, is it going to be a nurse, a physician, the pharmacist, social worker, dietitians, psychologist, or a family member? The method of communication, is it going to be face-to-face, face to a group, telephone in person, telephone mechanized, or internet? The intensity and complexity of the services being delivered, the duration, the frequency of being reviewed, the environment in which it's being given, and the outcomes we are basically being measured. Now, all this is relevant to getting a good outcome. So when you look at heart failure, and if you add in just one component, diabetes, and as the previous presenter has said, the amount of consideration you need to do to get optimal diabetic control, and the diabetic control in fact influences heart failure. And then you've got all these domains of care there, it becomes very, very complex delivering heart failure therapy in the community. So what basically does self-management do? Now the goals are clearly education. So there's about four or five goals with self-management. First is education. Now, if you sit in a classroom of people, not everybody is going to sit in a classroom is going to understand the same content. So this is the fundamental difference between passing an exam and delivering good medical care to patients. The education is delivered in one format. You get the same nurse or the same educator delivering the same format of education to a very diverse demography of patients. So that then instills how patients' behavioral responses to that and the ability to self-care. The content and the skills basically of the training staff and of the patient is relevant to good self-management. The intensity and the duration. Now this is very, very important again, because most of the funding models that are delivered for self-management are not delivered in the private sector, they're delivered in the public sector or public funded. And these courses usually go for about 4 to 6 weeks, a very intense cardiac rehabilitation, not followed up by ongoing follow-up. So I think this is a global problem that has not found a way to provide an education for a lifelong illness. So the education is cursory for a short period, and then the illness continues. And then how do you assess that the patient has reached an ability to to self-manage themselves and the components of which they require to be good self-managers. The staffing involved in delivering this and the delivery methods as well. Now, there's been a lot of literature published in this area, either meta-analysis, systematic reviews, and also independent studies. The Canadians have done a lot of good work in this area, and they've released what's called the Ontario Health Technology Assessment. So they've looked at specific things like using mobile phone platforms, self-management. And what they have found is basically the same way everybody finds is that, look, there is evidence out there, but the evidence is of a class B or class C, that means non-gold standard. So no trial has reached a randomized controlled trial as with a drug for you to say there's a class A1 indication. Now, there is a fundamental problem with this approach is that you're not actually comparing self-management versus best therapy. It is heart failure requires best therapy. Self-management enforces best therapy. So the question is, does self-management itself help improve optimal medical therapy? And if you do studies like that, you actually find that the questions you're being asked are very qualitative questions. Will the health system be satisfied? Will the patient be satisfied with providing good services? And most of the things would be yes, but health system does not go by quality to determine how medications and how medical care is delivered. So this is a fundamental problem with self-management. We're actually asking the wrong question and looking at the wrong outcomes when delivering it. We should basically say, look, education is very important to patients. They must attain a certain level of care, and the outcomes they're looking for is satisfaction rather than mortality outcomes. Those mortality outcomes should really come from delivering best therapy. And they also, a lot of the studies also found that the population is being used. And a lot of the countries that are being studied has also come from Africa, from the Middle East, from Asia, where they have lots of population and they want to find methods to do it. So Iran actually has a lot of work done on self-management, but the problem is obviously the numbers of patients in those studies and the homogeneousness of those population and how do you transfer them. But largely, a lot of those studies shows that hospitalization is reduced, but not significant for reduction in mortality. And that's not surprising because that's the wrong question being asked. So I will conclude here, and it was a short talk, that chronic disease self-management in heart failure has a lot of evidence, but if you're looking for mortality evidence, that is on the lower side. Chronic disease self-management has to be interpreted in many ways, can be interpreted in many ways. Regardless of how you interpret it, if you look at the trajectory in which heart failure is going and the cost of chronic disease management in the community, it is required to improve patient outcomes and reduce costs.
Thank you very much, Dr. Iyngkaran. And I would now like to open the floor to questions on his presentation.
Yes, thank you so much for this, short and brief, but to the point presentation. My question now is there any guidelines for self, care, or like the patient will be responsible about taking care of himself only depends on the education he get from the healthcare providers, or I mean everyone is fit to this, or there's no there's people that will be out of this list?
Look, you're spot on. I think. Can I just ask where are you from? It doesn't say. I know your name is Muhammad, right?
Yeah, I'm from Saudi Arabia. I'm a cardiopulmonary hub consultant working in a heart center in King Faisal Specialist Hospital.
Okay,
so we're dealing with a lot
of Max, the current chronic disease guy. He was doing some work with your hospitals there, trying to deliver a chronic disease program. Look, I mean, I'm happy for you to look me up because I think you asked an interesting question, and I think your country is interested in this. So there is no protocol that is written for self-management, as say, because you can see, right? if you talk about cardiology, and I'm sure you know in your hospital, even when you sit in your meetings, which cardiologist is really interested in talking about how to deliver chronic disease care to patients? It's impossible because they're more interested in stents, and that's fair enough. So this has to come in the realm of chronic diseases. But once you start talking about a realm of another specialty, specialties don't go well together. All right, so nobody's going to take a information from another specialty and add it to that. So yes, it is very, very poorly taught. Each specialty now should start taking over chronic diseases, and the nephrologists particularly and the diabetologists do this extremely well, and the respiratory. Cardiology has not done this so well. So if you talk about who educates, it really has to be a team. Now, patients who come into heart failure needs to be seen by a heart failure team, in which case the cardiologist leads the chronic disease heart failure team. And that education will start some aspects of the cardiologist, but it will continue with other members of the team, whether it's a rehabilitation team or the nurse and things like that. Then the question comes to who is funding these sort of programs, how the services come. The funding usually goes to a cardiac rehab stream, and that's only for 4 to 6 weeks. So the doctor doesn't really have time then to reinforce these sort of things. I think the core of which chronic disease is faceted must come into each individual specialty, and there must be a degree of either block funding or security of this if you want to make chronic disease successful and ensure that patients have some behavioral modification.
Absolutely agree. I think it's a multidisciplinary team management approach, I think. And thank you for bringing this up. Thank you.
Would you be interested in following this up? Because I think it's worth discussing that topic. If I asked Akshay or something for your details, would you be interested in writing something on this chronic disease on two perspectives? A Middle Eastern perspective and another perspective.
Sure. Why not? Here in Middle East, most of the medical care is a governmental, budget. So everything here is free. So I think maybe even studying the difference between insurance ones and non-insured one, and I think it's a good topic, and we will chat and see what we can do for that. Thank you. I appreciate that.
Yes, thank you again, Dr. Iyngkaran, and also